All right, you're gonna do great. All right. Good evening, everyone. Welcome to our 58th virtual shadowing session, Nursing Spotlight Med Surg with Mary RN. If you have any questions regarding our program, feel free to contact us at virtualshadowing.com, email us at virtualshadowing@gmail.com, message us on Instagram at virtualshadowing. And as always, this session is recorded and put on our YouTube channel right after pre-health virtual shadowing. This program is brought to you by our wonderful working group comprised of Reagan, Cheyenne, Taylor, Ollie, myself, Rachel, Miriam, Elena, Ani, Rohit, Kiana, Aditya, and our 4 physician providers, Dr. Fowler, Dr. Morchetti, Dr. Salazar, and Dr. Reno. If you like our program and want to see more, we have some great sessions coming up. Next week, we have a PA Spotlight, Acute Care and Surgery. This session will be starting at 8 p.m. Central Standard Time instead of our regular 7 p.m. Central Standard Time, so please be aware of that. After that, we have a Specialty Spotlight in General Surgery, and then after that, we have a DO Spotlight Air Force Family Medicine. If you want to see the full schedule for next month, stay tuned to our Instagram and our emails. All those sessions will be on Zoom or YouTube Live. If you have any questions for our provider tonight, please put it in the chat as we go along. We'll have 2 Q&As, one in the middle and one at the very end of the presentation. After the last Q&A, we'll give you information about the assessment so you can earn credit for this session. Without further ado, I would like to introduce our wonderful speaker tonight. She is an incredibly strong woman who's caring and puts everyone before herself, and she is so kind. She's known as one of the kindest souls in our family, and she is my cousin. So please give a warm welcome to Mary.
Thank you, Rachel. Thank you everyone for having me on here and for that awesome introduction. When Rachel told me about this, I thought it was super interesting. I love the idea of this program and really wished it was available during when I started nursing many years ago. So kudos to all of you in this working panel, just putting this on week after week. So I really commend you guys. To start off, I'm sure you guys have all heard so many different things about nursing and how stressful it can be. This lady seems pretty happy, seems to be 39, but yeah, so trust me putting on this presentation, it would probably be more stressful than doing anything with nursing. So bear with me here. You wanna go to the next slide? Yeah, so just a little bit about me. Our family, Rachel, my family, they immigrated from Vietnam during the war. We're very family oriented. We've got a huge family. Most of us live in Minnesota and the rest live in Texas or California from our mother's side. I was actually originally born in Houston, Texas, and our family moved up to Minnesota when our grandma got sick. She had a stroke and my mother moved us up here so that she could help take care of her mother. So I kind of saw that and just saw the caring side of taking care of others. And then on the bottom here, you see a lot of family, a lot of family. The bottom picture is actually Rachel's sister that got married last year. We're in there somewhere.
I'm here and then Mary's here. So this is just our mom's side.
Yeah, so
not all of us.
And not all of them are there. So that was a lot of fun.
Mm-hmm.
Yep. And then a little bit about me. So I have an older sister here that live in Minnesota that's a pharmacist. And then all of our other family members in Minnesota deal with business or computers of some sort, which does not interest me in the tiniest bit. So the only healthcare connection I have are my 4 younger cousins in Texas. 3 of them are doctors now who actually married doctors and another PA. So, and then of course, Rachel going to medical school. So very health oriented in Texas. Very smart. So why particularly did I want to be a nurse? Again, I've always been told all my life, I'm usually very calm, patient, and just a very caring person overall. I do tend to help others before myself. And so I just thought healthcare seemed to be the right fit. It's a very rewarding career. My favorite part is just watching the progression of patients getting better. They're unable to walk into the hospital, and then for them to walk out of the hospital is just major progress. So just seeing the progression of that is pretty cool. And the next slide. So this is my journey into medicine. As you can see, there's a picture of me on the left-hand side. That was me when I first started nursing, and then the one on the right is me today. So not much of a change. I've been in the healthcare field for 17 years. I was a nursing assistant for 4. So I started at the University of Minnesota with a 4-year degree in health and wellness. And during that time, I was a nursing assistant. And then I was I got my associate's degree. So it's just a 2-year degree in nursing at Inver Hills Community College. And then I became a nurse on the same unit that I was a nursing assistant on. So that kind of helped. Nowadays, I believe having the bachelor's or the BSN in nursing is highly encouraged. Most hospitals will only allow bachelor's of science in nursing when they start. So, and with that, there's so many different avenues for nursing, not just hospitals or clinics, but you can be a travel nurse, which has been a huge thing with the pandemics right now. And then a public health nurse, a flight nurse, all that stuff. And, getting that BSN is very highly encouraged. Some hospitals will even help pay for your tuition to help further your schooling. So that helps too. But that just wasn't my path at the time. So next slide. So I work on a med-surg or a medicine unit. This is a picture of my hospital. I work at the University of Minnesota Medical Center. There are 2 campuses, the East Bank and then the West Bank. The East Bank is mostly adults. West Bank has, there's a children's hospital over there, and then the psych unit and ortho over on the West Bank. Our unit consists of patients that are 18 and older. Most of them are they're not critically ill, pretty acute. They are most of them are able to walk and talk and alert and oriented. And a lot of them just go home from our unit or to a rehab facility. And then on, some occasions, if they're on comfort cares or hospice, they go down to the morgue. And also, patients have so many other comorbidities, so many other things going on with them than just what they came in with. And then being on a med-surg unit, it's probably the best place to start as a new grad. You see a lot of different things. You are able to perform many, many skills that you probably wouldn't be able to do on other specialized units. They say if you can work on a med-surg unit, you can work anywhere.
So is that why you've stayed on med-surg?
I stayed on med-surg just because I have floated to other units and it just didn't really fit for me. If anything, oncology would have been my next choice, but I think I just really liked my coworkers, and it really makes a difference on who you work with.
And home.
Yeah, it's my home for a long time.
That's cute.
Yeah. All right. Okay, so it's just a few of our patients that we typically get on a med-surg for. We get a lot of people that come in with abdominal pain, so like pancreatitis, and then a lot of diabetics. We do insulin drips on our unit. So basically, people with uncontrolled blood sugars, we adjust their insulin drip according to the protocol. I'm not sure how it is on other med-surg units, but I've been told that insulin drips are usually for ICUs, but on our hospital, it's we just get more critical patients, and it's considered med-surg. We get a lot of organ failures, like liver failures, renal failures. Sometimes when we get those renal failure patients, they go to dialysis, which is a different unit. And so they're off the floor for like 4 hours, which is kind of a nice little break. A lot of GI bleeds, alcohol withdrawals, and then those nursing home type patients who are total care, bed bound, incontinent. And then those few like suicidal ideations and 74-hour holds.
Wow,
That's just to name a few.
That's a lot of different types of patients. So
Yeah.
that's awesome that you are trained to deal with so many different types of patients and handling with all of them.
Mm-hmm. Yeah. So I have been at my job for that 17 years. And so I play many roles there. I'm a bedside nurse. I am a charge nurse. I precept, and I welcome new nurses during this time called like a didactic day, where we just spend like a few hours with them before they come onto the floor, and just make sure like their username and password work on the computer. They're able to get into the med room, just kind of familiarize themselves, with the unit and how things work. And then in the past, I've also helped with nursing instructors with nursing students, because we are a teaching hospital and they come quite often during the school year.
You have a lot of hats. Like our students are already being like, wow, that seems like a lot to handle. One of the students wants a little bit more clarification. What is a preceptor?
So a preceptor is like you're training a new nurse.
Gotcha.
Gotcha.
Cool.
So they either follow you on their first day and just kind of see how it's like, and then slowly take a patient or two and get them going on their own.
Awesome. Well, I'm glad that your hospital and your floor has a great preceptor like you.
Thank you. There's a lot of us, but yes. All right, next slide. I know everyone always asks about our shifts. A lot of us work the 12-hour shifts. So it's either 7 a.m. to 7:30 p.m. or 7 p. to 7 a. There's those 8-hour shifts, day, evening, nights, and then you can always pick up these 4-hour shifts that we like to call princess shifts. 12 hours a day sounds like a lot, but they don't schedule you more than 40 hours a week. So you're only working 2 or 3 days a week. But it can get long, or, on those busy days, it goes by fast. I don't think I know any nurse that works 40 hours a week, or a 1.0 shift. It's completely different working in the hospital than working I don't know, because I haven't worked in an office, but like a 9 to 5 sitting in front of a computer.
Wow. So like 3 shifts a week. Wow. So you can have a life outside of nursing, just not for like those 3 days.
Yeah.
Are nurses ever on call?
Yeah. So if we're overstaffed and we don't have that many patients, it depends on the hospital census and how many nurses are on. We do have a float pool of nurses who go to whatever units that are short, or whatever units that they're trained to be in. And if they're, able to take over those positions, then we can be on call, or even get something called an excused absence and just get to stay home if there's not enough patients.
So you mentioned that there's a float pool as well. So if there's like an overflow of patients, like who do you call first? The nurses on call, or the floaters, or like how does that kind of work?
Well, so they would automatically put those float nurses in the different units that are in need. And then after that, they would call whoever. If, like we would be staffed to the top of our matrix. And if there's still open beds, they'd have to call in a nurse to fill, to take those admits to fill those beds. Gotcha. So the float nurses usually take them.
Gotcha. Well, thanks for the clarification.
Yeah. And I'll go to the next slide. So it's not all stressful. We can have fun too. Here's a picture of me and my coworkers getting breakfast. We always try to make it up there before the breakfast time closes. And that was just one of the days that we actually made it up there. And so I had to just document it. So that was kind of fun. So basically, what is an RN? What do we do? I'm sure you guys hear it all the time. We are the eyes and ears of the healthcare providers. We're in their room a lot of the, like 90% of the time. And then the doctors will come and round on them and just stay for like 5-10 minutes, depending on how many questions the patient has. We multitask. We're good at that. And, not only are we the nurse, we are the housekeeper too. Sometimes we'll just take out the garbage, and also the personal waitress. Like, I don't know how many times I've gotten a cup of ice or a warm blanket or made some toast or anything like that. So
the nurse aides don't do that. You do that.
Well, we can do that, or they can do that too, but there's only so many aides on at a time, and they're busy. And so we do everything they do too.
So it's a teamwork effort. Love that.
Yes.
A student said, people better say please to you.
A lot of them do. There's a certain few that just,
Another student said, nurses are the backbone of our society, which I agree, and lots of other students agree with as well.
Oh, thank you. Yeah.
How is your relationship with other nurses or other providers on your floor, such as like doctors, PAs, nurse practitioners? Like, how closely do you work with them?
Oh, we talk to them quite often. They'll call us during their round, or the nurses on their round, and then we'll try to all like kind of round together with the patient so that everyone's all on the same page. A lot of them are very personable. Just last week, I think one of the doctors actually, I know because I was there, bought us all coffee at the coffee shop. So that was, there was like 8, 9, 10, like 12 of us on that day. So he bought a lot of us coffee.
Oh, sweet.
Yeah. And a lot of them are very professional, and I don't know if people know the big deal about July. July is coming, and that's when all the medical students like graduated and become interns. So they're brand new to the hospital, and they are like a deer in headlights, don't really know what's going on, so are nice to them, and vice versa.
Oh. That's great that you have such a great relationship with
Is that my internet connection?
I don't know. Dr. Fowler, is it me or is it Mary?
Well, I am hearing Mary's voice broken up a little bit, but let's just see where it goes.
Okay. It might be you, Mary. Can you hear me, Mary?
I can hear you.
Okay. You're
Can you hear me?
A little bit. Yeah, we can hear you. Let's just keep on going.
Okay.
Doing great. All right.
Okay. Are you on the next slide of what does an RN do?
Yes.
Okay. So not only are we those multitaskers that wear the many hats, so mainly we do administer the meds and monitor for side effects and reactions. And then a lot of our day is charting too. Just remember, what you chart is submissible to the courts if anything were to ever go that route, the legal route. We try to be as detailed as the day goes about patients' medical. Not only do we do that, we coordinate with so many other team members, as mentioned, not just the nurses and doctors that, are part of the care team. It's the social workers, the care coordinators, the like pharmacists, dietitians. There's a whole group of people that are concerned with the patient there. We're also big educators for their patients and families, and also the advocates for their patient and their families.
Mary, this is Fowler. A good question was just asked. What's the difference between a CNA and a care partner?
Like a care coordinator?
Or, yeah.
Mm-hmm. So a CNA is a nursing assistant. So they are there to assist the nurses with vital signs, beds and baths. The care coordinator is someone part of that coordinates care outside of the hospital, like their home care needs, any oxygen that they might need, or scheduling like dialysis outside of the hospital. They actually do not do any actual cares, but they can go into the patient's room and talk to them about their home needs.
It's so very important to carefully coordinate the care from within the hospital to the patient when they return home, so that, for example, they don't get worse if it can be avoided. Some people go home, go to bed, and then they get pressure sores, decubitus ulcers, and they come back sicker. So the careful coordination with the home environment is so important.
Yep.
I work in an academic setting. All the folks on here pretty much know. And, I work with our residents, the emergency medicine residents and the off-service rotators. And I tell them, you got to look at the whole patient. For example, if a little old Aunt Minnie who comes in with another problem is really quite frail, we're obliged to make sure she doesn't go home and fall, because if she breaks her hip, that could be the end of it.
Mm-hmm.
Please keep going.
Yeah.
I didn't mean to interrupt.
No, that's okay.
I like this slide.
Yeah, this is one of my favorite memes here. So basically, the day in the life of a nurse is it's just full of interruptions. Those beeping IVs. It's very fast paced. This nurse it's clearly photoshopped. There's not even a hair out of place. Her scrubs still look clean. Like she's smiling. She's happy. I mean, we are too sometimes, but it's pretty hectic. And every day is different. We carry these special phones as our pagers. They're called ASCOM phones at our hospital, and all of your patients' call lights go on them. All of like the abnormal tele rhythms, we do tele or cardiac monitoring on our unit as well. And then, doctors or other departments will call you. So it's just full of interruptions, and can be very distracting while you are talking to a patient. And then I think one of the worst nightmares for a nurse are those call lights. Like we'll just hear them, dream about them, but if you have a good team, teamwork makes the dream work, right?
Absolutely.
Yes. Okay. Smiley just came up here now. Okay. All right. So in a nutshell, a day in the life of a bedside RN. This is just my typical day. It's, obviously different everywhere and every day. A lot of us, there's just a lot of gross things in the hospitals. You definitely don't want to bring your shoes home. That's probably where all the things settle that you don't see. And some people even change out of their scrubs into their own clothes. So anyway, after you change your shoes and stuff, we'll do what we call like a high level report, where we all congregate either around our table in the break room or out in the hall, and talk about, the charge nurse from the previous shift will talk about how the night went, what patients to look out for, like this person's quick, you get to their bed alarm quick, or, which patients are discharging or not doing so well. So during that high level report, we'll listen and multitask and find out, look at our assignment, see who our patients are, who our aides are. On a day shift, you'll typically get 3 to 4 patients, along with evenings. On a night shift, there's 5 to 6. It's very rare that you get 6. It all depends on your staffing and how many nurses you get. And then after we do that, we do a bedside report where both the off-coming and the oncoming nurses will, sit outside the room or even in front of the patient and talk about them, why they're here, and, what their plan is for the day. We'll update the whiteboard and make sure that bed alarm is on if they need it. And then we will go back to the computer and look at all of our orders, look at labs, check in with our aides and our therapists during the day. It gets kind of busy with all of the different care teams working with the patient. You're spending most of your day passing meds and helping with ADLs. Our nursing assistants, we do everything too. So you will have to clean up poop every now and then. And sometimes we'll throw in some wound care changes and finish charting, doing our notes and education and care plan. And then of course, most importantly, we try to fit lunch in there or a break. Sometimes, I'll notice that I didn't even go to the bathroom for the first, however many hours. And then the day just goes so quick.
Wow. So this is a really like fast-paced, busy job.
Yeah.
And then, so do you have 3 to 4 patients yourself, and every other nurse also has like 3 to 4 patients?
Yep. If you start your shift off with 3 patients, expect to get an admit if there's an empty bed. So I always want to start off with 4 patients just because I don't know. No nurse likes getting an admit.
Mm-hmm. And then, so how many patients do you have on your floor typically?
We have a maximum of 25 patients on our unit. So
Gotcha.
I think that's pretty normal.
A student wants to know, do you ever get lunch with your patients?
No. I think I've had a patient ask if they want, they'll offer me their lunch just to be nice, but there's just kind of a weird line you just don't cross.
We have an interesting question. How feasible is it to make sure that the same nurses follow the same patients in order to ensure consistency of care? How do you coordinate with the nurses who assumes responsibility after your shift has ended?
Yeah, so that's a good question, which I think I touch up in the next couple of slides here in the charge nurse role. We do a continuity of care where we keep the same nurses and nursing assistants with the same patients, just to kind of keep things easier for the patient and the nurse to know like their routine of care, how they like things, and each day gets easier and easier, like you have a set routine and not have to look up things as often.
Gotcha. Cool.
Yeah. Good question. All right, here's the one word where nurses are kind of superstitious while we're working. And the taboo word of the day ever in the medical field or anything, you should just never say the word quiet. Like every single time someone says quiet, like all chaos breaks loose.
We say at my hospital, we say if you ever use the Q word and never use the Q word, a busload of diabetics will run into a trainload of hemophiliacs, and there'll be blood and pee everywhere.
Yep. It's a dangerous word. Like
I swear to God, the gods of medicine are listening if you use that word.
Yeah.
What has been the craziest experience after someone said the word quiet?
We had a code blue, so someone wasn't, breathing on their own or having issues. So we'd all run into that room and help the bedside nurse until the code team comes by and kicks everybody out that's not involved. I remember walking out and I saw a patient sneak outside, trying to leave with like her bags and everything, pretty much leaving AMA or, leaving against medical advice. And she clearly knows that she shouldn't leave, but it was the perfect opportunity when no one was at the desk watching her leave. So I followed her down up into like her car. And I remember looking at the driver and I'm like, are you seriously allowing her to leave? Like, this is not safe. But at that point, there was nothing I could do. I couldn't like put hands on her. She wasn't on a hold or anything like that. And so you just got to let the doctors know, and you can only try to convince her so much to stay.
Yeah, Mary, you used a word called a hold. Could you explain that?
Yeah, so sometimes we'll put patients, or the doctors will put patients on a 72-hour hold if Patients aren't mentally capable to make decisions on their own for their own safety. So when they're on a hold, we'll have like a sitter or a attendant, which is usually a nursing assistant, sit with them to make sure that they don't leave, so that we can figure out a better plan of care for them. Sometimes it could be a court hold where the court makes decisions for them for their medical care.
Mary, we had a question that came up a minute ago. I don't mean to get out of order. I mean, we're loving this talk of yours. Somebody asked this, Diana, I believe, she's heard nurses speak of crucial moments where they caught a physician's mistake and had a chance to see it corrected before the patient was affected. Have you had that happen to you in your career?
I'll see like a weird order. I mean, I can't like really pinpoint an exact time, but I remember there was a time I saw something that just didn't look out of place. And I'm like, is this on the wrong patient? And then like, oh yeah, shoot, that is. But it never like reached the patient, just because as nurses with our critical thinking skills, you got to think like, why are they ordering this for the patient? Is it, they're like, if someone was, I don't know, had a low potassium level and the doctor ordered Lasix or something, which is making them pee out all their urine, and that makes their potassium level go even lower, doesn't make any sense.
And, to some degree, the electronic record can cause error, because if you can have a whole bunch of records open at the same time, you might be writing on the wrong chart.
Yep.
It's possible. This is why we use Epic, and Epic at our shop, the medical record, will only allow us to have 2 charts open on the same computer, as opposed to the many that we used to have open.
Yeah, we use Epic as well. On my end, I think I can have up to 4 open at the same time. But yeah, it's dangerous having all that open.
And to follow up on, I'm sorry, I'm interrupting so much, but I'm really enjoying your talk, Mary. This is terrific. And I wish you could see all the chats that are, these folks are loving you, all 200 of them. Aww. And, but I use what I call a focus moment, where at some time on the patient's chart, I will stop and go through everything one last time, if you know what I mean, to make sure I see it one more time. It's just what I do.
Yeah. Do you copy and paste a lot?
That's a great question. And Epic doesn't like that. I'm sure you've seen the error messages when you're copying and pasting onto the wrong chart.
Yeah, so, well, I've seen notes where they'll like describe the patient as like a male, and it's clearly a female, and it just day after day it's the same thing. So I think
since we're talking about electronic medical records, there is now the trend across the country to where people have complete access to their medical records. And so if you were to make some kind of comment that was frankly rude about the patient, or even if you have a 300-pound guy and you call him obese, which he is large, that they can file a complaint. So it is kind of an odd time with patients now having more and more access to their own records.
We had a time, sorry, I know this is totally off subject, but we had a time where we would print up the doctor's notes from the day before. We called them open notes, and we would hand them to the patient, like what the doctors write about them, just so that they are more understanding of what is going on with their care. And a lot of them is medical jargon they don't understand. But yeah, there's some things that, doctors will say, and they're like, we're not agitated. I wasn't like that. I wasn't like that. I was nice to the nurses, or, something like that. So yeah, but we don't do that anymore. We just found that it gets left in the corner, and then that just becomes a whole HIPAA thing and all that stuff. So, but yeah.
Please keep going.
Okay. Okay. And then, did your slide show up, Rachel? Oh,
yes.
Okay.
So what does a charge nurse do?
Yeah. So these are just some of the qualities of a charge nurse. The most important quality, I think, is just the willingness to help others during that day, just being available and being able to answer questions. Usually charge nurses know a lot about the unit and can answer most of the questions that are being asked. We're an advocate not just for our patients and families, but also for the staff too. And then we usually don't have an assignment unless we're short-staffed. And then we should know just a little bit about our patient or each patient on the unit.
Oh my goodness, that's so, like, as a charge nurse, you'll have to know like 25 patients at a time, and even the nurses that are involved with them. Wow, that's great.
We ask the nurses. I'll ask if they have any updates or anything, or if they can tell me a little bit about their patient.
So how does one become a charge nurse? Do you have to do another certification to become a charge nurse? Like, what's that process like?
Nope. So you're a charge nurse on your unit. I think I just got grandfathered into it. I've been there for so long, but it's who our manager thinks would be ideal for that situation or that role. I know that a lot of the new grads start off on the night shift, and everybody who's been working longer will, get moved to days. And there's not very many patients or people that work nights. So after 6 months of being on the floor, they train you in to be charged, because there needs to be a charge nurse on nights. So it all depends on your abilities and what your manager sees.
Gotcha.
in you.
Do charge nurses change? Like, is there like a rotation of y'all? Is it just like one charge nurse for the floor and that's it?
Yeah, so we used to have something called the nursing unit lead position, where there would always be the same day charge nurse, and then the same evening, and then the same night. But we got rid of that position, and now a lot of us rotate with the nursing or the charge nurse role, which is kind of nice because it breaks up the week, and then I still like doing all the bedside care and seeing the patients. I mean, you still do that as a charge because you'll go into all the call light rooms when no one's at the desk, but it's a nice little change of pace.
Gotcha. Cool. Well, I would love to hear about the day in the life. Well, first, this meme.
Oh yeah. So I mean, I when I'm charged, I typically ask how patients are doing, or sorry, not patients, my staff are doing, like if they need any help. There'll be a time where I don't see one of the nurses and I'm like, oh gosh, I hope they're doing okay. Are they drowning? This one kind of just fits how a typical nurse could be drowning, with having 3 admits. Well, actually, we would never make you take 3 admits, but having a lot of admits, no lunch, haven't peed in 10 hours, and then your patient poops on your shoes. So that's like, after all that's happened, then the charge nurse will be like, oh, how's your day going? And they're like, I'm fine, but really they're drowning. So
Ugh, gross. Poop on the shoes. Good thing y'all have different shoes for work.
Yes. And there's like alcohol wipes and like big wipes and bleach wipes and stuff available all around, but who knows if that's clean enough,
Yeah, gotcha.
So,
so now I would like to hear the day in the life of a charge nurse.
Yeah, so we do that high level with everybody in the beginning of the day, and then the charge nurses will give each other report while everybody else is doing bedside report. And then after that, when I'm charged, or when the charge nurse will get on a call where all of the charge nurses on all the different units, including patient placement and the nursing supervisor, we'll all get on the call and just talk about our census. How many patients do we have? How many nurses do we have? What are our staffing needs for the next shift? And then the shift after. And then who's leaving, how many discharges we're getting, and what we can take. It's just a revolving door of patients. That meeting lasts between 15 to 20 minutes. And then we go back to the unit, get in our spot, and have a little charge checklist of our own to do of things around the unit.
Gotcha. Yeah. Next slide.
Yep. So we're, constantly checking on staff and answering call lights, phones. I mean, you just get interrupted there too, with people coming to the front desk asking like, oh, what room is this patient in? Or, can I get a consent form or something like that? So that's like a different type of interruption. And then around 1 o'clock, we'll talk with the social workers and the care coordinator. We'll all go through each individual patient and kind of see like, oh, are they ready for discharge? Or, how many more days are they going to be here and what are their needs? And then after that, that's, I'm constantly working on the next shift assignment throughout the day. It changes. We have discharges right at shift change, and then assignments get messed up. So then you have to adjust to that. You don't want one nurse to have all the discharges and then make them take all the admits. At least spread it out a little bit. And then on this little picture here, this is my unit's acuity guide. So this kind of shows us like all the different levels of patients that we have. So like acute patients are, they're mostly walkie-talkies. You don't have to go in their room very often. They're capable, but still need some sort of monitoring. An intermediate patient will probably have to go in there every couple of hours to give pain meds or, turn them, clean them up. And then another example of a complex patient would be, like that insulin drip, where we would go into their room every hour, checking their blood sugar and then adjusting the rate of that drip.
Oh, wow. So you have a schedule, you have a plan to like go to each room at a certain time. Wow.
Yeah. And then also this little guide shows us, if we can staff up a nurse or not to go above our matrix. So.
A student asked, does MedSurg try to group patients with similar needs together, or do you mix them with a variety of patients on a given day?
When I make assignments, or when most of us make assignments, I think of acuity first. So, there have been times where I have all three of my patients had abdominal pain or were pancreatitis. We would never try to have 3 liver patients together. That's a little much, especially if they're confused. But we usually do it by acuity and maybe isolation too, because putting on all that PPE takes some time. So, sometimes it happens where you have all the same similar type of patients, but
that's not
try
your
to mix
goal.
It
That's your goal is more based off acuity. Gotcha.
Yeah.
Cool.
Yeah.
So what is a new admit?
A new admission. This is nobody likes to get a new admission. It's just a new patient on the floor, but it takes a little bit of time. We call for report and make sure that they're appropriate for our unit. Again, on a med-surg unit, it's not as critical, or we just want to make sure the patient's stable to come to our unit. And the nursing assistants will set up the room, we'll grab the vitals, the height and weight. The 2 most important things are having, like the 2 nurses do like a 4-eye skin check, where we will I look at the patient from front to back, top to bottom, make sure that whatever they came in with for wounds is what they came in with and not what was acquired at the hospital. So good documentation on skin is a good thing during admission. And then also their belonging notes, just making sure they come in, they leave with what they come in with. Sometimes patients will be like, well, I had a diamond ring, or now I don't have it, but really we know if you would have a diamond ring or not, because that's jewelry is one of the most things that we look at.
Gotcha.
So, yes. And then the best part of coming home, my support system, my fiance Rocky, and then my dog Smiley. It's awesome just having that wiggle butt to come home to.
He's so cute.
Yes. Let's see. Next slide, I think. Mm-hmm. All right. So overall, if you're to pursue nursing, just one thing to remember, it's it's a 24-hour job, 24/7. The hospital never closes. There's always someone there to take after whatever you think you forgot to do. And sometimes you just don't have the time to do what's needed to do. Like patients are off the floor for however long and you can't give those meds. Just reschedule them. People understand. You don't take your work home. You don't chart at home at all. You just leave it there, and it stays there. And
Mary, can I interrupt that? So
Yeah.
you don't do charting from home, even if there was something that might have gotten forgotten?
No, we don't have access, I believe, to that, to Epic at Home as nurses. And I think, if you were to change something, you can do it like the next, or come back in and either edit a note or have, if it was like, oh, I forgot to chart that urine that I emptied out of that Foley, I'll just call up to the unit and be like, hey, can you just chart blah, blah, blah amount of urine for the output.
That's great that you don't have to take work home. My sisters are physicians and they're always charting at home. They're always trying to catch up. So it's great that when you get home, you can relax with your man and your baby.
I actually, over the last several years, because Epic has been so convenient to use and I can access it from home, I actually, before I go into we call them pods in my ER, I'll typically go over the charts before I go in, just so I can be familiar with the patient. But it's just my style.
Yeah.
And then as a nurse, can you choose to do other floors easily? Like, do you have to do more training or anything?
Yeah. Well, there's so many different things you can do with nursing with all those different pathways, but training to a different floors is pretty easy. Well, like going to oncology, you'll have to get chemo certified, just like the specialized areas are more specific and they'll train you in to do that. Yeah, it's not the most glamorous job being a nurse, but it's very rewarding, just knowing that you made a huge difference. It's just instant gratification, definite job security, and who doesn't like wearing pajamas to work? Scrubs are pretty comfortable. So
I think that's a reason why I want to be in medicine, just comfort. Love being comfortable.
Now they have those like fashionable scrubs.
Yeah.
Those figs.
All right.
Yeah.
Well, we have a lot of questions. Students are absolutely loving your presentation so far. So a common question that students want to know is like, what do you do on your time off? You only work maybe like 3-4 shifts a week. What do you do in your free time?
I sleep. No, I just relax, Netflix, try to work out, I guess I can say. But yeah, just catch up on anything that I couldn't do around the house during the time that I worked. But yeah, mostly just try to sleep, hang out with my dog.
Mm-hmm. Do you take any night shifts currently, or do you typically go for night shifts, or are you more like day shifts?
I started off doing day nights. So I did work a lot of night shifts. It's hard on your body. The shift itself, it wasn't as crazy. I mean, don't get me wrong, not all patients sleep at night, especially on our unit. So it does get kind of crazy on nights and you do have more patients. So it gets you kind of busier that way. I prefer days. It works better for me. I'm a day person, not a night owl. And
Mary, do you have a lot of monitors on your ward, so you start getting alarm fatigue?
Yes. Yep. I hear beeps in my sleep, like bed alarms, bathroom lights, call lights, like anything, telephones. It's you do. I sit at the desk a lot, so I hear it all. And then there's just some that just tune it out, sadly. They tune it out because we just are tired of it.
In the ER at an academic institution, I'm so grateful for med students because, those alarms get lost. I mean, they're just going off. So I'll send the med student, go see what that is.
Oh, I wish our med students did that.
So we have a question of like, do you have any advice for someone who's starting out with night shifts of like how to get through the night, awake and ready?
A lot of our night crew will, they'll go home in the morning and either take a Benadryl or a melatonin, something to just kind of help them sleep. I remember when I was working, I would be so tired going home. I'd try to like fall asleep in that first hour. I'd most likely shower just because of all the
Grossness.
stuff. Yeah. And then I sleep, but I only sleep for a few hours. I'll wake up around noon, because I do have like the dark shades and blinds in my bedroom, but somehow I just can only sleep for a few hours, and then I'll stay awake and just relax or do whatever around the house, and then I'll try to go to sleep like again at 7 for a few more hours until like 10, and get up and do the shift.
I have become regularly using melatonin now for the last several years, and I'll take it about 2 hours before I'm ready to lie down. And I find that seems to help me, plus the darkened room, as you say.
Yeah. Yeah, it takes a little while for the melatonin to kind of kick in.
One of the things that gets
patients. Sorry.
One of the things that gets addressed a lot about burnout among medical personnel, nurses, physicians, and so forth, is if they cannot take care of their physical health and they end up getting really tired and start, beginning to question, well, why am I doing this? This job is wearing me out. So for all the folks listening tonight, part of your job approaching your career is going to be working on taking care of yourself.
Mm-hmm. Yeah, if you can't take care of yourself, you can't take care of others.
That's right.
So your health is just as important.
That's very important. I think a lot of students need to hear that. So a student asked, what are the pros and cons of working a day shift versus a night shift?
The day shift goes by really fast. Just so many different things going on, a lot more people, doctors, the procedures that happen, therapies there. And then it's obviously nice to work during normal working hours. The night shift, it is a little bit slower some days. It all depends on the night. There's less people around. So, I mean, if you're not all about being around the manager, she's never there on nights. But our manager is awesome. She's very cool. And there is that incentive with some extra pay on your hourly.
So, Mary, are y'all hurting for nurses?
So I think we've been getting a lot of new nurses lately, so I think we're staffed, but there's always a nursing shortage, and especially nursing assistants nowadays. I think they stopped, everything stopped last March or April during the pandemic, the beginning of the pandemic, where, they stopped all the emergency surgeries and any non-emergent people that don't need to go to the hospital. So at that time, they were actually having mandated nurses to stay home and use our PTO. So they didn't hire many at that time, but now everything's getting kind of back to normal. We're getting back to that shortage of nurses, and all the patients that never came in during the pandemic are a lot sicker now. So the hospitals they're just, once a bed empties, another one fills. It's just a constant revolving door.
Yeah, I hope everybody can recall that slide you had earlier in your talk that showed all the different diagnoses that you have on your med-surg floor, from hemodialysis to somebody pre-op, somebody post-op, folks from nursing homes who require nearly total care, and so on and so on. So you have the wide range of medical humanity on your floor.
Mm-hmm. I'm sure I forgot a couple more, but yeah.
Yeah. What did COVID do to your hospital? I mean, were you seeing COVID?
So I worked on it's on our slide, towards the end, but
okay, well that's fine. Yeah.
We can just talk about it after.
We'll talk about it later.
Okay.
Sneak peek. We're talking about COVID later.
Yes.
A couple other questions that we have is, which do you like more, doing new admissions or doing discharge instruction?
I think I know the answer to that.
Discharges. If they're discharging home, that's even better. You just literally go through their discharge paperwork, or even a facility. You don't really have to go over the paperwork with the patient, but you just have to give a report to the oncoming or the facility that they're going to. It's nice seeing a patient get better and leave, or if it's a not so nice patient, it's also nice to see them leave too. So,
Mary, I'm sure y'all have a 24-hour psychiatric service in your hospital. And so I would
it's
imagine
on the West Bank. Yeah.
I beg your pardon.
Oh, it's on the different campus, but our medicine unit, actually, I feel like we become a med psych unit sometimes.
Yeah.
Another comorbidity.
And do you have to deal much with the agitated patients that have to be sedated?
We try not to sedate them as much. We'll give them like the Ativan or anything to kind of calm them down, but it doesn't work half the time, the medications. So at that point, we do have to put an attendant in to make sure that they're safe. If it gets really violent, we'll restrain them with wrist restraints. And then if it gets really bad, then we'll have to call security and stuff. So
we're in development of yet another card course called Advanced Mental Health Life Support. It'll be a 4-hour program that deals with such things as prone positioning with the knee in the back. If you do chemically sedate somebody, what are the essential elements of what you have to do to monitor their condition and so on. So, but that's what's happened with society, you know.
I do live in Minnesota, so all that stuff was here in Minnesota about, just all the different things, restraints and stuff.
And of course, you were mentioning pancreatitis, so I'm sure you're doing a lot of the CWA protocols on. Do you mind explaining to the students what CWA is?
Yeah, I don't know what it is off the top of my head, what COS stands for, but it's the alcohol withdrawal protocol where patients will come in, with a blood alcohol of, I don't know, they're still talking and everything with 2 or 3 times above the legal limit of alcohol. We do have a lot of alcoholics that come in, and we just have to monitor. There's like in your charting, like what's their respirations like, see if they have, tremors or if they're sweating. There's all these little different things that kind of add up, and depending on their score, we'll give them oral Ativan or Valium. We don't do IV on the med-surg unit. If they need the frequent IV doses, then they would go to higher level or the ICU.
I had to look up CWA. It's Clinical Institute Withdrawal Assessment for Alcohol. That's what it stands for. Yep. I forgot too.
We're all learning tonight. That's so great. Okay, I'm going to do one more question and then we can move on to the second half. So a student asked, I've seen memes or other contents from seasoned nurses about the dynamic between nurses and new doctors and residents. With July coming up, is this a common phenomenon, and how is it resolved?
Yeah, so I did mention that earlier. Sometimes I forget about July until people are like, oh, July is coming, and July literally is a couple days away here. But you'll notice, like very timid interns and orders that just don't look right, or they'll be asking a lot of questions and stuff. We typically are very nice to the newbies. We know how it is. So a lot of us, we
were all young at one point. We were all young at one point.
Exactly.
Someone had to be patient with us too.
Mm-hmm.
That's great that the newbies are coming in with such a welcoming environment. Well, I'm excited to hear about some of the patients that you have on the med-surg floor. So are you ready to move on?
I think so, yeah. So one of the many, huh?
He just coughed.
Okay. One of the many patients that we typically see, although lately it hasn't been quite as bad, but hepatic encephalopathy patients, which are, sorry, there's all this noise in the kitchen now, which are very confused patients. They come in this particular scenario, the patient has altered mental status with a history of alcohol cirrhosis. And then they can also have other issues like renal failure or other comorbidities as well. So they come up to the unit. They're unable to ambulate to the bed. So we have to pull them over with this hover mat, which is a mat that they are on, and we inflate with air and just kind of slide them over, just another back saving device. And there's a whole, the next slide is all of like what you would typically see in a hepatic encephalopathy patient or a patient with liver failure. Not all, but most are, confused, disoriented, agitated, irritable, just wanting to leave. You'll notice that once you get enough of these, you'll see that their blood pressures are usually soft. They have like tachycardia, so high heart rates, and then sometimes even low oxygenation on room air. Most of them have like this distended belly, so it looks like they're 9 months pregnant. It's full of ascites fluid. They're jaundiced or yellow, like you'll see yellowing in the eyes. And then a lot of them are very swollen and have, very like this +3 edema, which I have a little picture down there. It's basically all the fluid that's, built up in mostly the extremities, sometimes in your stomach or on the side, like your flank. But when you press down on the patient's skin and it leaves that indentation, that is edema. And then the higher the number, it starts with 0, goes up to 4 or even 4+. The higher the number, the worse the edema is, like depending on how long that indentation stays.
That's a deep indentation.
And so,
yeah, I've had to.
So Mary, on this patient, this is someone who has just had a terrible alcohol problem for a long, long time, and he or she may or may not stop drinking. And how do you keep from being frustrated when you work so hard on a patient like this, but somehow just getting through to them that they've got to work on their own health?
You can only say so much, and they can only take so much in. They'll tell you like, yeah, I want to quit, I need help. And then that's when like the social worker or care coordinator will come in and help them find, places to help with rehab and getting them back on their feet. But then you see them back in the hospital like weeks later with the same exact issue. It is frustrating. It's hard. We do get what we call those frequent flyers. They come back for the same thing, but it's like, do you want to keep doing this to yourself is basically what I say, but kind of in a more respectful way. This is not the way to live. And a lot of them just, may be sick enough to be on that transplant list if they're, sober for 6 months or however it is. There's a whole transplant team that works up each patient with all the tests and stuff to see if they're eligible. But yeah, it's hard dealing with patients that just, have their own way of thinking, and nothing's going to change it.
I found in the ER that my trying to verbally, the word, I guess, intervene to try to help people move on to the next phase and stop this self-destruction. Excuse me. I don't find that it seems to help very much. I'll keep trying, but it doesn't seem to help much.
Yeah, that's all you can do is just keep trying. But yeah, I agree. It really doesn't. It's kind of sad. So yeah. Another thing with hepatic encephalopathy is to focus on lab levels, there's so many different labs, that we check on patients, but the ammonia level is one we look at for their confusion. I mean, it's not just indicative of the ammonia level, but other things could contribute. That higher the ammonia level, the more we understand why they're confused. They're not able to just excrete all those toxins out. And then you'll see, the edematous, the edema in the extremities from either low or high sodium with all that fluid retention. So that's one of the things we look at. And also the bilirubin, which is the coloring, that yellow coloring. And sometimes with low hemoglobins will give blood.
So if you see any of these levels being too high or too low, like what's the next step?
Definitely notify the doctors. We do have an electrolyte, like RN managed electrolyte protocol that we can initiate ourselves. It's mostly like potassium, magnesium, phosphorus. Depending on what those levels are, we can replace it ourselves, but it's always checked with the pharmacist as well.
Oh, cool. Gotcha. I'm glad that you can like intervene really quickly so like the patient can get quick care. It's really cool. All right, next slide.
Yes. So a nursing intervention for a patient that's super confused. Falls is a major thing we are working on our unit. They are so confused and unsteady on their feet. So this is like a picture of a bed, the end of a bed. This is our iBed, or like it's a smart bed. And we have all these different zones for safety that we can put them on.
Let me, yeah, my fell asleep. Yeah, here we go.
So there's 3 zones that we do. A lot of them are just on that first zone where, it's not so restrictive. If they put a leg over the rail, then it'll alarm, and it's this huge, long, loud screech until you turn it off. And then the middle one is like if they sit up in bed, then the alarm will go off. And then the third one is the most restrictive. These are for those quick patients. Just even lifting up your arm is going to alarm. So again, most of them are on that first one. And then that green light below that, it just shows that the iBed is on, just letting the nurses know that either the bed alarm is on or everything is set how you set that iBed. And you can see that from the hallway.
So you don't have to run if you hear any of these alarms go
literally, yes, we have this patient right now that, she's literally right across from the desk. We try to keep all of our fall risk patients closer to the desk so we can get in there in a timely manner. But yeah, we literally run in there, and you could knock people over with the speed of, some people running into those rooms. She has fallen so many times, so we just couldn't deal with another fall.
Mm-hmm. Well, I'm glad you're right there and you're ready to take care of them if they do fall.
Mm-hmm. Let's see, next one. At our hospital, I'm not sure at the university or in Texas, we have this West Haven hepatic encephalopathy protocol, and this is initiated by nurses as well if we see any patients that have any confusion symptoms from hepatic encephalopathy. Lactulose is something we give quite often for liver patients. That helps pretty much, it makes the patient poop out all the bad toxins. So we give it either orally if they're alert enough. Sometimes we'll have to do it rectally, give them rectal enema, or sometimes even put in an NG tube through their nose and push that lactulose in that way. And depending on, if they get better or not, usually with liver patients, doctors will want 3 to 4 bowel movements a day. But with hepatic encephalopathy, you just keep giving it until they clear up a little bit with their mentation, their mental status.
Gotcha.
Yeah.
So what are the stages of West Haven, or West Haven stages?
Yeah, so there's 4 of them. If you want to go on the next slide there, Rachel. The first stage is, the most alert. They're confused, but they're still able to talk to you. And then stage 2, they just increasingly get more drowsy, but they are still able to talk to you. 3 and 4, they're not responsive at all. And that's when they go to higher level of care. 1 and 2 is what we mostly get on our med-surg unit. And yeah, it's fun dealing with agitated patients.
If you ever have an agitated patient that you can't, or you need help with, like, do you call on like other nurses? Do you immediately call security? Like, who
we get
helps you?
nurses, and anybody on the staff will help. And then if it gets too out of control, we will call security, or it's a code 21 is what we usually call it for any security help or a violent patient.
Gotcha. Well, I'm glad that you have a good team to like depend on. Teamwork makes the dream work.
Yes. Yep. And then this next one, patients, with their diet, you got to limit their salt with all that retention and restrict their fluids. Patients don't like that very much, and always try to sneak into the nutrition room, which our nutrition room is locked. So they always try to get like ice water or something, and they know they shouldn't have as much. Sometimes they're very malnourished and will need to get a feeding tube placed. That's either through their nose or even get a peg tube placed in their belly. And if they're unable to swallow meds, we crush them up and push them through that tube. Sometimes that tube gets clogged, and this picture just kind of shows, what a mess it can be once all that stuff comes splattering back in your face. So
that
another
like a fun time.
Yes, I learned quickly the first time and never again. If I meet resistance, I will stop.
Lesson learned.
Yeah. And then there's a procedure called a paracentesis. As mentioned before, a lot of these liver patients have those distended bellies filled with ascites fluid, and the doctors on our unit will come up to the bedside and aspirate a ton of fluid from their belly, and that helps them breathe better. Just think about a big belly just pushing up on your diaphragm and stuff, having a hard time breathing. So that's done quite often on our unit. Yeah. Another thing that we get quite a bit on our unit are patients with the C. diff infection. That is a bacteria in your colon that causes a bunch of diarrhea. So this patient came into the ED, they have abdominal cramping, pain, tons and tons of diarrhea that's lasting 4 to 5 days. And then they did all the stool tests and saw that they were positive for C. diff. And so once we get a patient with that, we immediately place them into a private room. Definitely don't want to share anything that a C. diff patient touches with another patient. We put them in something called enteric isolation, where you wear your gowns and gloves, and then proper hand washing with soap and water is a must. The foam that you're supposed to foam in and out with doesn't kill those bacteria spores, so soap and water is the way to go. In every isolation room, we usually have disposable stethoscopes. I can never hear anything out of those, so I do bring my own in and then wipe it down with bleach. Like bleach wipes are the ones that kill those spores instead of the alcohol ones that we have.
Some of our students are going, "Oh no, C. diff." They know this is a bad case. And then another student said, "I've heard a few C. diff horror stories from friends. Do you have any horror stories you are willing to share with us?"
There's always a story. There's always a nursing story with anything. It's the worst when the patient can't get up themselves and they are constantly, it is a constant flow of stool. Like, just, you clean them up, you get them a fresh brief on, and they go again. It's just a constant battle of wiping patients. And the stool itself is, once you see it, you can't you won't forget it. Like it's mucusy. Sometimes you'll see like it looks kind of seedy sometimes. There's a very distinct smell. It's very odorous. I can't really like describe it, but I mean, on our unit, we have like, the lactulose poop smell. It's pretty sweet. And you can see what it looks like, by just looking at it, that's lactulose. And then there's C. diff. And then we have like GI bleeds with bloody poop. That's probably worse than C. diff. I don't know. That's kind of a toss up. And then the normal poops. So, it's
How
just,
do you deal with the smell?
Well, luckily now, I don't know how it is in Texas, but we still wear masks, just surgical masks, all the time in our hospital, and either like goggles or face shields. We still have to wear the eye protective gear and then a surgical mask. It doesn't really mask the smell, but at least they can't see your face gagging when you're like cleaning it up.
So a pro that came from, COVID and whatnot.
Yes, I guess. If we have to do a pro from it.
One light.
Yes, I always got to look at the positive. And then this slide, so C. diff is it's highly contagious, spreads through the fecal oral route. That's why I stress that hand washing is very important after coming out of a C. diff room. And nurses, we oftentimes clean up a patient, no matter what kind of condition or stool they have. And then we go to lunch right afterwards, not just, it's like, it's nothing to us. It's just like another day. And then we even talk about it during lunch and what we saw. So it doesn't really faze us. And then let's see, when patients come in with diarrhea, you automatically think that Imodium might help slow that diarrhea down, but it doesn't work for C. diff. They use oral vancomycin now to help with that. And then sometimes if the cases are really bad, then they have like a fecal transplant that may be needed, where it's literally donated stool from someone close to you, and either give it through like nasally or rectally, or I think even in a pill form. They can compound it into a pill and then you just swallow it. So,
but it's like medically processed, right? It's not
yes,
just straight from the toilet.
It's not like you're eating poop. And then this meme is, it never fails. It's anybody in an isolation room. They want to be nice, they see how hard you're working. They're like, oh, here's a piece of candy. Do you want this? Take this, share it to your coworkers and stuff. And I mean, you got to be polite. You got to say yes, thank you, or no, thank you. But, if I were to take it, I would just obviously put it in the garbage. I usually don't eat anything that my patients give me.
I love this face on this meme. It's just like, no.
Yeah. Yeah. I mean, there are nice patients out there. It's just gross when it comes from an isolation room. So, yeah. All right. And then the COVID. So I don't want to get like too in depth with COVID. It's still there. On a med-surg unit, we didn't get very many like critical complex patients. We didn't get anybody on a vent from COVID. That's more of the ICU. I was fortunate enough to not have to like set up an iPad and say their, like last goodbyes to their family members, like many of you have seen in the news last year. This Sheila is my wonderful colleague that, is all geared up in COVID gear. This was towards the beginning when, it was still new. Not everybody knew what was going on about it. So we were covered head to toe. And all you could see were the eyes. Like the patients are scared. We limit so much contact. They're in there by themselves. We have an iPad and a phone that will just call into the patient. And so this is her way of showing like, we're here. This is who I am. She took a picture of her badge and blew it up to like an 8x10 piece of paper and brought it to her patients' rooms, covered it up in, a Ziploc bag to not get infected and stuff, and just leave it on like a shelf in the room, just to show that the patients that, hey, I'm your nurse. This is me under all of this gear. So she actually did an interview on the news about it. And I mean, there's so many different interviews and stories about nurses during the pandemic, or the beginning of it. So she was part of it, and I thought that was very cool.
Did you ever feel like putting on all this PPE like hindered any of your care for your patients, like connecting with your patients?
I mean, they don't see much of you but your eyes. I mean, I'm sure half of them don't even know what our faces look like. We do have like a bulletin board with all of our pictures, whether you're a nurse, a pharmacist, CNA, up on the board. So like I see patients sometimes walking in the hallway nowadays when they're allowed to walk out in the hallway, look and stare and be like, oh, that's my nurse, because we're still wearing the masks. So nowadays it's more lenient, and we still wear all of our PPE, but it's not quite as scary as it was in the beginning, I guess you can say.
I'm glad, working now is not as scary, and I'm glad, COVID is lightening up. So
yeah, and we weren't like the main COVID unit. It'd just be off and on. Our sister unit next to us is also a medicine unit, was the main COVID unit, but we still took our fair share, and now all the units are taking them pretty much. So
gotcha.
Yep. So during COVID, we would definitely put them, in their private room. We try to put them in a negative airflow room, which on my unit there's only one. And basically with the negative airflow room, it's, the pressure in the room is a lot lower than the pressure outside. So once that door opens, like all those dangerous particles will stay in the room. It doesn't come out. We still, follow all the special precautions with our N95s, our gown, our gloves, our face shield, basically what Sheila looked like. But now a lot of us don't wear like the head, we don't cover our hair as much as we did in the beginning. A lot of our COVID patients don't even have symptoms, but they have other things going on. So we help them take care of that. A lot of them just need like supplemental oxygen. We just monitor their their vital signs, and just, make them comfortable while they are going through and dealing with getting better. And then on occasion.
Mary, actually, a question just popped up. Especially with COVID, so many people getting so sick. Have there been times when you've actually cried in front of a patient? Some people would handle that a bit differently, but have you ever choked up in front of a patient before?
Not with COVID, just because our unit specifically doesn't have like those really critical ill COVID patients, but we do get our fair share of comfort care patients dying from other things. And, you'll see all the family in there, and I've talked to patients before they went downhill, and just seeing that is kind of sad. I personally have not cried in front of a patient, but there have been a handful of us that have. So it happens. I think it happens more in the ICU though. On my unit, it's not quite as critical.
Well, especially when you have them for a long time, weeks maybe, and you develop a relationship with them, and then in spite of everything we do, they just slip away, and it's hard.
Mm-hmm.
I find the times I just sort of have to walk away,
Yeah.
But also patients, they appreciate when you're sensitive, but what you don't want to do is start boo-hooing in front of the patient, because there is an air of professionalism that we have to maintain.
Yep. I like to sometimes sit down at eye level with the patient, just make them so they're not like looking up at you all the time, and just kind of talk to them as if I'm their friend, but like you said, there is a line that you just don't want to cross too. So
you sit on the bed and hold their hand sometimes?
Sometimes, yeah, if they're crying themselves, I will definitely, or even like just rub their back a little bit.
Do you
yeah,
think
it's not-
patients, I mean, you've been doing this 17 years, I've been doing it 40. Do you think patients want this contact with their healthcare providers, or do you think it kind of puts them off a little bit if you're sitting on the bed holding their hand?
I guess you kind of just gotta know the patient or just read the patient. You know, if you can see that they're not comfortable, then obviously get up from the bed. But I feel like sitting down on the bed and talking to them really helps. So yeah. And then some more things with dealing with COVID patients. You know, we have those iPads that you guys have probably seen in the news. And then in the beginning, like we would limit the contact. We would even call them on their iPads. No, sorry. Miley, no.
Smiley wants to come on.
Yes, she does not. Stop.
Oh, I see her.
Okay. So yeah, if the patients are COVID positive, you know, like no visitors at all, our visiting policy has slowly been lifted and coming back to normal. So, and then also patients, you know, they do stay here for a long time on our unit sometimes, and we'll retest them for COVID every 10 days to make sure that they're still good, especially if we need to place them in a facility.
How long does an average patient like stay there?
We've had patients stay as you know, as short as less than 24 hours, or someone for like 4 or 5 months. It just all depends on placement and if they're on a court hold, and then we got to wait for the court date and all that stuff. So,
oh wow.
yeah.
So with all these changes at your work due to COVID, do you see any of those changes still being implemented after COVID? Like, do you still see like the iPads or like still wearing face masks everywhere?
Yep. We still have the iPads. I don't see the doctors using them quite as often. There might be some specialties that might still have you bring the iPad in the room to talk to the patients, because if they're not on campus, it might be easier that way, or they'll just call them on their telephone. We still wear our face shield or our goggles, and then just a surgical mask every day, all the time at work, unless you're eating. So it's really definitely dehydrated us. Like we don't think about drinking water as much because we have that.
Have a mask in the way and it's making it a hassle. Yeah, definitely can get that vibe.
Yeah, in the beginning it was real funny just watching people try to drink and it's just like all over their mask.
Oh no.
I think we're just all used to it now.
Mary, you're letting family come in to the rooms now, now that we're so much further along in the epidemic.
Yeah, so our visitor, it's been every week, it's been getting better and better. It used to be just like one visitor per stay the whole time, and we can't rotate visitors, but you know, and then in a couple weeks later, we can have 2 visitors if they're in a private room, and then you can rotate them every day. And now patients are allowed to go outside, which they weren't able to go before. It's getting nicer outside, and it's hard for them just to be held up in their room, and there's only so much TV you can watch and walk around in the unit. So it's nice to just get that breath of fresh air. A lot of our patients do smoke too, so it's not, you know, it's still prohibited, but I don't know, I'm sure they find a way to get that in without oxygen.
Find a way.
Do you require patients' families to be vaccinated before they can come in?
I do not believe so. They just have to be on our on the patient's like designated visitor list. Yeah.
So you mentioned that, you know, you don't deal with like intense COVID patients, like they're asymptomatic, and like if they're coming to your floor, they have other like issues going on. Like, how do you deal with like a patient that says needs an insulin drip and needs to be checked in every hour, and they also have COVID?
Yeah, so we just got to be very strategic about making that specific nurse's assignment. We actually did have a patient on an insulin drip, and they were COVID positive. I believe they were symptomatic too. So I think we just gave that nurse less patients, maybe just three patients. And those 3 patients were very like right next to the room of the COVID patient with the insulin drip. And with insulin drips, yeah, the nurse still has to go in there every hour to change the rate or if it needs to be changed, but you can always work that out with your nursing assistant on, like you'll get the odd hour blood sugar checks, and then the nursing assistant will get like the even hours or something. So it's not like you're doing a lot more work. You're still having to change, the drip rate depending on what that blood sugar is. So it's more time consuming just putting on all that PPE correctly and safely.
I can imagine. So did you spread out the COVID patients on your floor? Did you have like one nurse deal with all the COVID patients? So how did you assign, COVID patients?
In the beginning, I mean, it was a work in process. For every day it changes. In the beginning, we tried to save or like just reserve a certain block of rooms for COVID patients. And then in the beginning, we would just have one nurse. We call them like the dirty nurse that would, just have those patients. And then in the beginning, we didn't even have aides that could go in there, just with not having to go room to room and, potentially spread the COVID. So, but then there's times where you just there's patients that can't get up and you can't just do everything on your own. So you do have to have another person go in and help you.
Mary,
did
your hospital require y'all to be vaccinated?
They did not require us, but a lot of us did it. A lot of us are vaccinated. It was not a requirement. Yeah. Is it in Texas?
Depends place to place. A hospital system down in Houston recently got in an uproar by telling employees, get the vaccine or you're fired. And needless to say, lawsuit was filed.
I can see that.
Oh yeah.
Well, we're at our last Q&A, and this has been a great presentation. We have a lot of questions, so do you mind, spending a couple more minutes, answering our questions?
Yeah, I'll try.
I won't steal you from Smiley for too much longer.
I know. Can you hear her whining? She probably needs to get let out.
She's
sorry.
Cute. I love her. So some of our students asked, like, why nursing? Why not, MD or PA or DO, or like, why not even nurse practitioner? Like, why did you stay as a nurse? Or why did you choose nurse?
For me personally, I just didn't want to do any more schooling. Like, I just felt like what I did was enough at the time.
Mm-hmm.
So, but I mean, by all means, the more education that you can get, the better. So that's me personally.
Yeah, understandable. Everyone, has a different lifestyle, and you got to figure out what fits you and what's best for you in your life. So earlier you mentioned that there's like different avenues for nursing. Can you talk about some of those different avenues? Like, we talked about nurse practitioner, we talked about nurse anesthetist. Like, what else is there?
Oh gosh. That's a good question. I mean, those are the 2 main ones that I can think of off the top of my head right now. We see a lot of nurse practitioners in the hospital, and I don't really I don't work with most of the surgery people, so that's where they'll see all the nurse anesthetists. But you can work in different fields.
Yeah, in the ER at Parkland, we work side by side with nursing practitioners and PAs, and we love them. They are an inherent part of our infrastructure of getting patients through the ER.
Yep. And they can prescribe meds, so that helps too. Sorry, I didn't really answer that question. So
that's okay. But I'm glad to know, like, there's lots of different options if you choose the nursing route. Like, you can go into different fields, you can go have a higher education if you want to. So like, nursing field is such a great and broad field to be in. Oh, a student said flight nurse, military nurse, dispatch nurse, school nurse. You can also do all of those too, which I think that's also incredible fields and also incredible like positions to be in if that suits your like lifestyle.
Possibilities are endless.
Yeah.
So Mary, how long do you think you'll work? Will you work until one day you're found blue and stiff and cold in the hospital? Will you pass away on the job, or do you see yourself working 20 years, 25, 30 years? I'm at 44 and I don't plan to quit. What are you going to do?
Yeah, I think I'll be a lifer on my unit.
A lifer.
I think I know it's bad to say, but I feel very comfortable on my unit. And I love my schedule. Things are just good for me there. So
another question, Mary, do you find that you have to read and study pretty much all the time, or do you think, what does your career require of you? I have to read all the time.
Yeah, so we do have required learnings. They're constantly giving us all these little modules to do just to kind of keep up with the new technology in healthcare and all the new equipments that come up. And then every 2 years, we still have to do all of our what do you call it? Those education hours to renew our licenses. For nurses, it's every 2 years, and you got to have like 24 hours of the continuing education.
Yeah.
Yes. Yep. So yeah, I mean,
you're kind of in an academic environment. Do you like it there, or why at the university rather than say in a suburban hospital? What made that decision for you?
So I went to the school at the University of Minnesota, so I knew the campus pretty well, and I worked at the hospital there. There are many other Fairviews or mHealths around the state. I actually live out in the suburbs, so there is a closer hospital to me. My commute is about 25 to 30 minutes one way to go downtown. And then there's a hospital that's probably like 10 minutes away from me. But I'm just so used to the type of patients that we have on our unit. And I just feel like if I went to a different facility, it's not quite as like complex. And those, I wouldn't say boring. I shouldn't say boring. It just wouldn't be the same type of patients. Like those are the patients that get transferred to us from those suburban small hospitals.
Well, that list you had of some very, very sick people. For example, the hepatic encephalopathy. For example, critically ill dialysis patients that are so sick, hyperkalemic and so on and so on.
Mm-hmm. Yep.
Speaking of all the different types of patients, somebody asked, how's it like dealing with so many different types of patients and illnesses? Does it get overwhelming? Does it get confusing? Like, how do you handle all that?
I feel like we see it quite often, like the same type. Like sometimes we'll have like a group of patients that are just all liver patients. It's like, oh, it's the liver time. Or then, someone with a lot of like chest tubes, or a lot of people on BiPAP, or, the PCA pancreatitis patients where it's at the pain pump. So I'm just so used to it. They're pretty common, like the type of patients that come on our unit.
So a question is like, do you remember like the curriculum for becoming a nurse? Like, can you briefly share about that? I know it wasn't too long ago for you, but do you remember like how long it was? Like, what did you have to do?
Well, there's so many different programs out there, like the BSN, the 4-year nursing program, the associates, the 2-year nursing program. And then there's also like a MSN program and accelerated programs. So if you have a bachelor's degree in something else, you can do this MSN for the Masters of Nursing program and I think that's like an accelerated year and a half program beyond your bachelor's degree in something else. So I don't.
Well, you can go on and get a doctorate in nursing.
Yeah, the NP. Yeah.
So you can get like, you can have school for like 4 years all the way to what, like 8 years. Wow, that's crazy.
Yeah.
Very flexible, very flexible.
Yes.
Do you work closely with CNAs on your floor?
Yes. Yep. We always are asking our aides to help out, and we give them report, kind of telling them about the patients that we have with them and what we need from them, like vitals, like if it's every 4 hours, or, you know, like their blood sugars. This is how the patient moves, you know. So yes, we are always in constant contact with them.
Gotcha. And then, so some students still want to know about like shift life and whatnot. Do you work consecutive days, or do you work like every other day? Like, how do you balance life?
So they try not to give us, so I only work a maximum of 3 12-hour shifts in a row. So that's 36 hours in a row. Back then, when I was doing just my 12 hours on my weekends, I would work, and I had a mix of 12 and 8-hour shifts. I would work, you know, it's like 7 days in a row, starting off with my 3 12s and then 4 8s. And that got really tiring. Yeah, a lot of us did that before we were able to go to straight 12s. And that was, you know, you definitely did not want to see us or talk to us on day 5 or, you know, 6 or something. We're just crabby and just, you know, not happy. But currently I only work 2 or 3 days a week, which is really nice. So, but they're long days.
I bet, like 12-hour days, goodness gracious. So, you know, you mentioned there's day shifts and night shifts. Have you ever had to do like a day shift and then a night shift after? And then do you have any advice for people that are like switching between shifts?
Yeah, so I got lucky because when I did a day and a night shift in the same week, it always started off as a day shift, and then the next day I'd have a night shift. So it wasn't like a huge difference, but there are a lot of nurses that do a night shift and then they go home. Let's say like they work on a Sunday night and they go home Monday morning, and then they'll come back on Tuesday morning and work a day shift. And that is very, very hard. I think all they do is just try to sleep and try to make it through the day. Yeah.
So can nurses prescribe any medication? I know, what about nurse practitioners?
I'm sorry. No, nurses cannot prescribe any medications. Nurse practitioners, yes.
Gotcha. Do you know if they're limited or anything, or
limited for nurse practitioners?
Yeah.
Our nurse practitioners can pretty much, I think they can prescribe anything. They prescribe pain meds and narcotics. And they pretty much act as the doctor, and but there is a doctor that oversees them too, a medical doctor. So.
Gotcha. And then I think we'll take like 1 or 2 more questions, but like, so you've mentioned that, you know, sometimes you deal with difficult patients or sometimes it's a rough day. Like, how do you compartment, like, how do you make sure that that doesn't carry over to the next patient, you know, dealing with a patient that may not say, you know, please or thank you, or, you know, that like is violent? How do you make sure that you're not bringing that over to another patient?
Yeah, so we, you know, you can just step away for a little bit, take a breather, go in the back room, kind of just recollect your thoughts, and then go on to the next room. Just kind of take a little time to yourself before you go on to the next.
So really breathe, take care of yourself before you take care of others.
Yes.
I think Smiley wants her mom back.
I think she needs to go outside, but of course.
Right. Well, that's all the questions that I have for right now, or have right now. Dr. Fowler, do you have any additional questions you want to ask?
Oh, I don't think so, Mary. What a wonderful talk! We kept you almost 2 hours, and we're so very, very grateful to get to know you. Typically, we will have several thousand people watch each of these programs over time. Each one of them will be a medical provider and see 100,000 patients in a career. So tonight you've touched hundreds of millions of lives through these students. So we just want to thank you so much for your kindness and the great skill. And we're just deeply, deeply grateful, Mary.
Well, thank you for having me, and hopefully I was able to answer some of the questions. And
you did great. If you look at the chat, there are like thank yous just pouring in. They loved it. I loved it. Thank you so much for donating your time tonight. It was really eye-opening to learn about med-surg because honestly, I didn't know about this field or this unit. Sorry, I didn't know what you did until recently.
I mean, there's so much more, but that could go on for hours. So.
All right, let me talk about the quiz real fast. So we have quiz 58. It's open now, so you can take your, sorry, I keep on hitting this. You can take your phone, scan the QR code. We also post this link on our website, on our Instagram, and we'll send it out in our email tomorrow. This is due next week. I'm so sorry. It's supposed to be 7/6. I don't know why I keep on changing that. It's supposed to be due 7/6 at 6:59. Hi, Smiley. PM Central Standard Time. So keep on pressing next until you finish the assessment, and make sure you click download for the certificate.
I'm just gonna let her out really quick, but you can still talk. Sorry.
Okay, if you don't download the certificate, we cannot have any record of you doing your shadowing with us. Also, remember that assessment number 57 is still open from the PA Spotlight Orthopedic Surgery from last week. It is due this Thursday at 6:59 p.m. Central Standard Time. And again, this quiz, assessment 58, is due next Tuesday, 7/6 at 6:59 p.m. Central Standard Time. All right. Mary, thank you so much for coming. This meant the world to me. You are obviously my favorite cousin for doing this.
Yes, thank you.
Yeah, thank you all for joining us tonight. And I hope to see you guys in the future in the next sessions. Good night.
Thank you, everyone.
Good night, everybody.
Bye.